Hi, good morning, everybody. I'm Dr. Helen Malherbe from Rare Diseases South Africa, and welcome to the third Rare Research webinar of 2023. We've got a packed schedule ahead of us for the next hour, so fasten your safety belts. We've got three speakers today, rather a different approach from our when we have one sole speaker and dedicated to that discussion, but we've got a very interesting plan this morning. We've got three different speakers from the University of Cape Town talking about different aspects related to metabolic diseases in South Africa. And without further ado, I'm going to introduce briefly Ms. Sarah Lampert, who is currently a PhD student and medical scientist intern in the Division of Chemical Pathology at UCT. And yeah, over to you, Sarah. We're going to have a talk for 15 minutes, and then we'll take questions directly after the first speaker for 5 minutes. Please feel free to drop any questions in the Q&A. You can also drop down in the chat and specify who you are, where you're from, what your affiliation is. So maybe we can connect more with you afterwards. So over to you, Sarah, and enjoy the webinar. Thanks.
Thanks for the introduction, Helen. I'm going to turn off my video for the talk just to conserve bandwidth. So this morning I'll be presenting a study that forms part of my PhD. So this is a retrospective audit of inherited metabolic disease diagnoses in Cape Town, South Africa. So I've introduced this. So what I found really useful at the newborn screening event that we had earlier this year was an introduction to some of the common terms. So a rare disease is a disease that affects less than 1 in 2,000 people. An inherited metabolic disease is a type of rare disease with a genetic cause that disrupts cellular metabolism. And newborn screening is a public healthcare program where neonates are tested for a panel of treatable diseases shortly after birth. And the majority of these diseases will not have any clinical presentation at the time of testing. So there's no national newborn screening program in South Africa, whereas this is commonplace elsewhere in the world. Less than 1% of newborns are screened for any rare disease at birth. And as you'll hear later from Mariam, babies born in the Western Cape Metro receive a formal thyroid stimulating hormone measurement on cord blood shortly after birth. So there is expanded newborn screening available to private patients via the Potchefstroom Laboratory for Inborn Errors of Metabolism in the Northwest Province. However, this only accounts for 3 to 4% of the target population. In the absence of newborn screening, the National Health Laboratory Services diagnostic laboratories at Groote Hospital and Red Cross War Memorial Children's Hospital offer the only state-run laboratory testing for genetic testing for inherited metabolic diseases and urine organic acid testing via gas chromatography mass spectrometry. And due to the expertise of these labs in diagnosing IMDs, most of the country's IMD queries and referrals from both the public and private healthcare sectors are received by these services. Like other countries globally, South Africa has a relatively high prevalence of common IMDs, such as congenital hypothyroidism and cystic fibrosis. Additionally, prior research has estimated that South Africa has higher newborn incidences for galactosemia, glutaric aciduria, cystinosis, and mitochondrial DNA depletion syndrome 6, which I'll be referring to as African MPV 17-related neurohepatopathy. This has been attributed to relatively high carrier frequencies of common pathogenic variants for each of these disorders, likely due to founder effects. So there's a large data deficit on rare diseases in South Africa, since there's no prioritization of these diseases in the public or private healthcare sector due to the heavy burden of infectious diseases in our population. So the genetic services are there, but they're very stretched. And many patients remain undiagnosed or misdiagnosed, and the majority of patients are likely dying. So it's important for us to investigate the presence and estimate of cumulative incidence of all IMDs in South Africa so that we can better inform potential newborn screening programs in the future. So we essentially conducted 2 retrospective audits. One was on the urine organic acid test data between 2015 and 2021, and the other audit was on our IMD database and repository, which contains all the biochemical testing and genetic testing positive diagnoses. So we received ethics from the University of Cape Town to analyze anonymized data, and we cleaned and analyzed the urine organic acid data using this data. So the aims were to determine which disorders are diagnosed using urine organic acid testing, to determine the spectrum of all IMDs, not just organic acidureas diagnosed by our services between 2005 and 2021, and to determine the homozygosity of common pathogenic variants in our population. So we received a total of 9,198 organic acid testing requests. However, 130 of these requests were cancelled, resulting in 9,068 tests that were actually conducted. So the large majority of these profiles were unremarkable. However, 15% had an altered metabolic profile. The majority of these had metabolic derangements not indicative of an IMD, so immature liver function or some sort of mitochondrial dysfunction, and only 1% of the tests resulted in the diagnosis of an IMD. So these can be broken down into the different disorders, and the most common diagnoses were glutaric aciduria, propionic acidemia, ornithine transcarbamylase deficiency, multiple acell CoA dehydrogenase deficiency, phenylketonuria, cystinuria, and 3-methylproteanyl CoA carboxylase deficiency. Overall, looking at our database, a total of 613 IMDs representing 70 individual disorders were diagnosed by our services between 2005 and 2021. So this is obviously quite squished in this slide, but the most common disorders were cystinosis, galactosemia, glutaric aciduria type 1, and African MPV17 related neurohepatopathy. So a third of these diagnoses with the orange bars were diagnosed through genetic testing, while the remaining 2/3 were diagnosed through biochemical testing, some of which is the urine organic acid testing. However, for cystinosis, we measured leukocyte cysteine. For GALT, we do enzyme activity, and there are other specific biochemical tests for some of the other disorders. So I thought I'd just go into the 4 most common disorders that we diagnosed. So African MPV17 related neurohepatopathy, which you'll hear a lot more about in Surita's talk, is a mitochondrial respiratory chain disorder with presentation in the neonatal period with failure to thrive, hypotonia, liver failure, and jaundice. As with many other mitochondrial diseases, there aren't any reliable biochemical markers, and diagnosis has to be made using genetic testing. So the common pathogenic variants in our population with 100% homozygosity is the Q36X mutation. And this means that all of the patients that we've diagnosed in our population have the exact same variant in this gene. Unfortunately, there's no treatment available at the moment, and this disorder is always fatal before the age of 2. Next, we have galactosemia. So this is a disorder of carbohydrate metabolism where affected individuals are unable to break down galactose into lactose and glucose. So again, this presents in the neonatal period with difficulty feeding, vomiting, and hepatomegaly. And this is in response to breast milk, which contains galactose. So biochemical markers for this disorder are galactitol, galactose, and decreased enzyme activity for the affected protein. And there is 95% homozygosity for the common variant, which is S135L. Luckily, this is a treatable disorder and with relatively simple treatment, in that a simple dietary change, so a lactose-free diet, is able to provide an almost normal life for these individuals. Cystinosis is a lysosomal disorder that presents slightly later on in infancy, typically with Fanconi syndrome, which is a disorder of the kidney, failure to thrive, and if this is left undiagnosed for too long, the affected individuals can develop cystine crystals in the eyes, among other places. So biochemically, this is typically diagnosed through elevated leukocyte cysteine. However, it's also very successfully diagnosed genetically with 92% homozygosity for the common pathogenic variant D324AFSX44. And this is also treatable, although the treatment is more expensive, but cysteamine is a very widely used treatment for this disorder. Lastly, glutaric aciduria type 1 is an organic aciduria. So this as well presents in later infancy with macrocephaly, dyskinesia, and hypotonia. This is one of the 4 disorders that we do diagnose with urine organic acid testing, and we're able to detect 3-hydroxyglutaric acid and glutaric acid. And glutaralkyl carnitine can be measured when we do an acyl carnitine screen. So this has the lowest homozygosity. So there are more individuals with this disorder that have different pathogenic variants, but the common one in this population is A293T in the glutaralkyl dehydrogenase protein. So this is also a treatment amenable to dietary intervention with a low lysine diet and oral carnitine supplementation, contributing to a good quality of life for these individuals. So in conclusion, both urine organic acid analysis and genetic testing are powerful diagnostic tools in the absence of newborn screening, such as in South Africa. And they result in the majority of the diagnoses that we're making. So South Africa has some of the highest incidences of African MPV-17 related neurohepatopathy, galactosemia, cystinosis, and glutaric aciduria type 1. All 4 of these disorders display extremely high levels of homozygosity for common pathogenic variants, which suggests that molecular screening could be a promising first-line approach for newborn screening in South Africa. This would allow us to detect the majority of these patients with these disorders, since the average homozygosity for these mutations is 90%. So in order for newborn screening to be successful in South Africa, we need a program suited to our needs. And although that might not be what the rest of the globe is using, we obviously have to be very sensitive to the unique needs of our population and the available resources. So we suggest that molecular screening could be a good option. But we also need improved collaboration with experts across the country and across the globe. So I'd like to thank the co-investigators on the study, as well as my primary PhD supervisors, and then UCT, NHLS, and then NRF for funding this research. And I'm happy to take any questions.
Great, thank you so much, Sarah. That was very interesting. If you wouldn't mind just stop sharing your screen so we can just put you onto video a minute. That would be great. So I see that there haven't been any questions that have popped up, but and feel free to drop them now, either in the chat, but preferably in the Q&A. Sorry, you're still sharing your screen, Sarah?
Oh, sorry, stop share.
And one question that comes to mind, I mean, obviously, of your 4 examples there, one of them has a very simple treatment in terms of, a lactose-free diet, for example, and one of the other conditions is just not treatable. And this is often an ongoing debate that we have, is why would you want, it's almost, the argument that comes forward is that it's unethical to actually diagnose a condition if there's no treatment. Now, from a patient perspective, we say, well, actually, it gives the family some closure. Just having a diagnosis can actually be a relief in so many regards, that even though there's no treatment, at least you know what you're dealing with. Have you got any other perspectives to add to that, from a researcher perspective, maybe?
So no, definitely, and that's something that would definitely be heavily discussed if this turned out to be an approach we use for newborn screening. As you say, it's typically, you're not including diseases that are untreatable. So there is ongoing research into developing treatments for this disorder, but I think that we would exclude it from screening until there was a readily available and affordable treatment.
And I guess at least, I mean, there are a large number of conditions that don't have treatment, and at least those patients, I mean, they will still need palliative care, end-of-life care, to ensure dignity and so on. So I think that's important to ensure that we can quantify the burden of disease in terms of the scale. Surita, you had your hand up.
I was just thinking as well that, diagnosing these cases are not really, I mean, if we can't do anything about it, is not necessarily going to help that particular patient, but it does help the family for future pregnancies and gives them options for future pregnancies, because these are terrifying disorders to have to deal with as a parent. So if you know what caused your disease in your first child, you can always be offered options for prenatal screening.
Yes, and I see Jody in the chat has actually raised the same issue. Obviously, the risk of reoccurrence and so on with inherited conditions, and also ensuring that so that the families and the parents can make informed decisions around, reproductive choices and so on. So, yeah, great point. Always one that comes up as a philosophical discussion in many different fora. So we don't seem to have any other questions. So I'm going to propose that we move on to our second speaker, and we can come back and have other questions at the very end if others arise. So Surita, you're up next. And Surita Meldau is a senior medical research scientist in the chemical pathology unit, also at UCT. And it's there within the NHLS as well that she oversees the Inherited Metabolic Diseases Molecular Diagnostic Lab. And she specializes in metabolic disease genetic diagnostics with a specific emphasis on mitochondrial pathology, and currently chairs the South African Mitochondrial Disease Network. And her main research focus is on elucidating the landscape of mitochondrial disorders in the South African setting. And Surita is going to speak to us about a particular mitochondrial neurohepatopathy in South Africa. Over to you, Surita. Thanks.
Thanks. I just want to make sure that you guys are all seeing my screen.
Yes, we can. It's all good.
Great. Okay, so Sarah very nicely started this topic about MPV17 deficiency in South Africa. And I'm going to expand a little bit and talk a bit more about this disease, which recently we was basically completely outside of our radar, and that most people in the world has actually never even heard of. I've got a lot to cover in a short space of time, so I apologize in advance if I'm going to speak a little bit fast. I think to do that. Just see. Oh, no, I'm stuck as well. Oh dear. There we go. Okay. So the South African MPV17 story is one that has evolved over a number of years now. It started years back when our amazing pediatric GIT specialists at Red Cross Children's Hospital, I've been seeing a number of cases over many years that all seem to be presenting with some form of liver disease with a strong metabolic component. We strongly suspected a mitochondrial dysfunction, but we could never find a genetic cause in the most obvious places and using the diagnostic tools that were available to us at the time. Liver biopsies from some of these cases all had similar histological pictures showing evidence of bile flow defects, the accumulation of lipid droplets, which is typical for mitochondrial dysfunction in liver, and mitochondrial ultrastructural changes on electron microscopy, specifically the finding of large crowded mitochondria in liver cells. The biochemical tests showed very high serum lactates in the patients, which again can be a marker for mitochondrial disease, though it's a very non-specific finding. And metabolic screening in urine showed, again, increased lactate together with elevated liver markers and other non-specific markers of mitochondrial dysfunction. So everything basically pointed to a form of mitochondrial disease, but the exact cause remained elusive. So early in 2015, we had another two of these completely unrelated cases presented to the GIT ward at Red Cross Children's Hospital at the same time, both with a very similar clinical and biochemical picture to the previous cases, including the ones that are highlighted here: failure to thrive, neonatal jaundice, hepatomegaly, which is basically enlarged livers, episodes of hypoglycemia with, again, raised serum lactate levels. And in one of these cases, we had liver biopsies, which again looked very similar to the ones that I described in the previous slide. So in both of these cases, as with many of the others, we ended up excluding a lot of the other common causes of liver disease, including, for instance, galactosemia, which you also heard about a bit in the previous talk. Right. So we scraped together some funding and we did exome sequencing in both of these cases, followed by analysis of the data with a carefully devised tiered analysis plan, starting with the group of genes that we felt were the strongest candidates based on a review of the latest literature on mitochondrial liver disorders at the time. Lo and behold, we found this single homozygous nonsense variant in exon 3 of the MPV17 gene in both cases. So at first glance, this mutation is predicted to be a simple nonsense variant with clear pathogenicity. However, the South African MPV17 mutation is in fact a very interesting one from a scientific perspective, and a great example of why you should never assume that a variant does what it is predicted to do without confirming. So I apologize if this sounds a bit technical, but for those of you in the audience with a scientific genetic background, this may be quite interesting. I'm just going to quickly run over what this variant does. So the 106C to T change in exon 3 of the MPV17 gene results in a coding change, which would substitute a glutamine of position 36 of the MPV17 protein to a termination codon. This therefore would presumably introduce a premature stop codon in exon 3, which would likely severely affect the protein function and would be a target of nonsense-mediated mRNA decay by the cellular mechanisms. However, when we looked a bit closer at the predominant mRNA in our patients compared to controls, we found that patients with this variant lack exon 3 completely from their predominant mRNA species. So it turns out this particular variant sits on top of a conserved sequence motif called an exonic splice enhancer site, or an ESE, which masks it from the splice mechanisms which need to recognize exon 3 as something to be included in the mature mRNA, which then goes on and codes for the protein. So the result of this lack of exon 3 in the mRNA causes a frame shift in the coding sequence from the end of exon 2, with the new premature termination codon being introduced 49 amino acids later in exon 4. So basically the same effect, just different to what was expected. Okay, so what is this disorder? And to answer that question, we first need to look at what mitochondrial DNA is. So mitochondrial DNA is a small circular DNA molecule that's found in multiple copies inside our mitochondria, which carries the genetic instructions for making some of the essential tools that our bodies need to turn the energy that we get from our food that we eat into a form of energy that our bodies can use, namely ATP. So unlike our chromosomal DNA, which most of us are more familiar with, in which we inherit one copy each from both of our parents, mitochondrial DNA is strictly inherited from our mothers. But the machinery needed for the synthesis, the repair, and the maintenance of mitochondrial DNA is dependent on proteins that are encoded by genes in our chromosomal DNA. So these two separate genomes, the mitochondrial DNA and the chromosomal DNA that we carry in our cells, are in fact highly dependent on each other for their existence. Now, MPV17 deficiency forms part of a small subgroup of inherited defects in mitochondrial energy production or mitochondrial disorders. It all arise as a result of genetic defects in those nuclear DNA genes that are actively involved in maintaining, copying, and protecting our mitochondrial DNA molecules so that our bodies can make energy. Quite a mouthful, right? MPV17 mitochondrial DNA depletion syndrome, as we call it, is an autosomal recessive disorder, meaning that you have to inherit two defective nuclear DNA gene copies, one from each parent. And it's mainly characterized by infantile onset liver dysfunction, often resulting in liver failure, as well as neurological features such as developmental delay, hypotonia, muscle weakness, and neuropathy. Although in some rare cases, it presents in adulthood with a Charcot-Marie tooth type axonal neuropathy. It's a fatal disorder in about 70% of described cases outside of South Africa, and it is vanishingly rare worldwide, being seen mainly in the context of consanguinity in isolated families, except for a founder variant in the Navajo population in North America, where it was first described. The exact function of the MPV17 protein is still unclear, although it seems to be important for maintaining a healthy pool of DNA building blocks, called DNTPs, inside the mitochondria, and or for regulating mitochondrial membrane potential and ROS homeostasis. Whatever the mechanism of disease, when the MPV17 protein is defective, there's a significant drop in mitochondrial DNA copy numbers inside our mitochondria, especially in the liver of affected children. So after finding these two unrelated cases with the same homozygous variant and knowing that we've seen similar cases come through the ward in the past, we decided to look at the frequency of this variant in our local population by screening DNA extracted from 750 random newborns from the thyroid screening program that was mentioned earlier. And we found a staggering carrier frequency of 1 in 68 Black South African newborns in the Western Cape, which gives a predicted incidence of just over 1 in 18,000 births. So this is very high for an autosomal recessive disorder, but it's similar to the frequencies of some of our other IMDs, like galactosemia and glutaria that Sarah mentioned in the talk. Not entirely surprising. Once we knew what to look for, we started diagnosing more and more of these cases, and very quickly we built up a cohort of 24 confirmed cases that we managed to publish in late 2017, which was only about 3 years after first identifying the cause in those two cases. To date, we've diagnosed actually more than 60 patients with this disease in the South African diagnostic setting. And on average, we see about 1 case every month or 2, making this one of the most commonly diagnosed rare disorders in South Africa. Clinically, these kids present between the ages of about 2 days and 11 months, with the majority showing onset at about 4 to 5 months of age. Phenotypic presentation is severe as a result of this genetic defect. And death in all of our cases has been in infancy, so a little bit different to the 70% described elsewhere. Likely due to either respiratory complications from the myopathy or due to fulminant liver failure. So those kids that present in the neonatal stages, interestingly, seem to be doing a lot worse with quicker progression and earlier death. I'll come back to this a little later in the talk. The main symptoms are listed here. It's again similar to what I've had before: failure to thrive, neonatal jaundice, increased liver enzymes, progressive hypotonia with proximal muscle weakness, global motor delay, lactatemia, hypoalbuminemia, hypoglycemic episodes, and coagulopathies. So currently, there's not much we can do for these kids, as we've alluded to before. And to date, all of our positive cases have died before the age of 2 years. There are some limited studies looking at supplementation with nucleosides that are the building blocks of DNA that seem promising in other mitochondrial DNA maintenance defects like TK2 deficiency and RRM2B defects. And although some preliminary findings seem to indicate that it may be useful for MPV17 as well, at the moment there's no drug that can deliver it straight to the liver where it's needed. And there's always the possibility of gene therapy in the future. And some groups have started looking at that for MPV17 as well, but obviously that's still a long way down the road. The fact remains that we still don't know enough about what this protein actually does. And if you don't know what something does or how it works, then you won't know how to fix it when it is broken. So more work is needed to look at the actual disease mechanisms. So, as I've mentioned before, this is an ultra-rare disease in other parts of the world, making it very difficult to study the disease etiology. There's a founder variant in the Navajo population in North America where the disease was first described, but the variant in that population seems to be milder than the one affecting our patients, leading to defective protein rather than the absence of protein. And as with so many other mitochondrial disorders that we know of, there's a wide variation in the clinical phenotype amongst patients carrying that variant. However, the South African MPV17 cohort gives us a unique opportunity to study the natural history of this disease in the absence of any functional protein, since it can affect a knockout mutation. So our patients have identical mutations and near identical clinical presentations. There are subtle differences, such as the age of first presentation and the quicker progression in neonatal versus infantile onset cases that I mentioned before. One clue to this discrepancy has already come from our observations that nearly all of the neonatal cases, the neonatal onset cases, were on NRTIs for prevention of mother-to-child transmission of HIV. But this association needs to be further defined and documented. So we've recently embarked on this multi-center natural history study involving at least 4 university hospital settings from across South Africa, and our first 4 patients have been enrolled. So the idea with the study is actually I've just lost my track. So the idea of the study is to not only actually look at what causes the disease in our patients and the clinical presentations of the disease and the progression of the disease, but also to really start to get a look at sharing clinical expertise and standardizing treatment strategies for our patients, because so little is known about this disease as a whole and how to treat it, as well as to get a national infrastructure ready for when treatments like nucleoside replacement therapy or gene therapy trials do eventually come along. It's also there to give us the chance to build up a repository for samples to be able to study the disease progression as it affects the patients. So the second arm of this natural history study will be digging into as much of the retrospective case data as we can from our hospital folders and laboratory information systems. One of these projects are currently underway. This is Malishka Perumal on the slide you see here, one of our medical scientist interns. She's started recently to carefully collate and analyze our urine organic acid findings from our retrospective cohort to see if we can find shared markers or patterns in the biochemical profiles in our existing data that can be used to not only diagnose cases, but to monitor disease progression. We're very excited to see what data comes out of this project. And then in parallel to the natural history study, we've been actively working on a patient-derived skin fibroblast model of disease. So by halting the proliferation of these cells, we're able to mimic the mitochondrial DNA depletion that's generally only seen in the liver of affected patients. And we hope to be able to use this model for a number of studies looking into the disease mechanism. So I'm just briefly going to mention 2 of these studies. The first is an MSc project of one of my students, Sarah Adam, which is now turning into a PhD study. She's looking at the effects of NRTI treatment at the prevention for the prevention of mother-to-child transmission of HIV on the mitochondrial health in affected cell lines, specifically on mitochondrial DNA copy number and mitochondrial membrane potential, ROS production, and respiratory function. So these pretty cool pictures that you see here are from part of her project, which she's doing in collaboration with the Northwest University Mitochondrial Research Group, showing differences in mitochondrial membrane potential in patient fibroblasts with and without treatment with AZT, compared to untreated and treated controls. And finally, I'm going to highlight the study by Daryl Kamadu, who is another MSc student who has just joined our group in July this year. So he will be looking at the extent of oxidative damage to the mitochondrial DNA in our patient fibroblast cell lines to see if we can delve a bit deeper into the mechanism underlying the depletion. And that's it from me. I hope I was fast enough. I just want to quickly take this opportunity to highlight that the 3rd week of September, 18 to 24 September, is World Mitochondrial Disease Week. And this picture of Groote Hospital lit up in green is from last year with Mitochondrial Disease Week to raise awareness for this disease, this group of disorders. That's it.
Great. Thanks so much, Surita. Thanks for a really interesting presentation and for keeping to time so well. And I think we're making a big note on that Awareness Week later this month. So we'll definitely have to align some of our social media with that. So I see that no questions have come up on the Q&A and there aren't any comments on the chat either. But I think the thing that really comes to mind, and I'm a big picture thinker, is that there's so much amazing research going on in South Africa and so many people literally waiting in the wings to actually come in and collaborate and work together and really pull the national newborn screening program together, that it's just a case of all the stars need to align, and the money needs to come, and there needs to be commitment and a government level and so on. But we've definitely got the right people in the right places that are doing the work. So what do you think that we need to do to take it to the next level?
So yeah, definitely, if there's one thing that I've learned over the last couple of years is that working in isolation does not get you anywhere, and trying to do everything yourself doesn't get you anywhere. Collaboration is 100% key to moving this forward. I think if COVID taught us anything, it's that working together on diseases and things that affect lots of people are definitely the only way to move forward quickly, rather than working in these little silos. So yes, that's my thoughts.
Yes, yeah, no, I completely agree. And I think we almost need to be evangelistic about it. So I see that there's a question popped up now from Machaba, with the potential achievement of nucleoside replacement into the liver, potentially prolonging life. What are the considerations regarding quality of life, regarding neuronal and potential cognitive functioning, presuming the mitochondrial dysfunction would still significantly be affecting the neurons? Would you like to answer that live?
Yeah, no, that's fine. It is a very, very important question, and it is definitely something that we are already thinking about, seeing that nucleoside replacement therapy is on the cards, as you mentioned it. So that is definitely something that we just don't know at this stage. So we don't know, because our patients are so severely affected by their livers, we don't know to what extent they will be affected. Should we correct that defect in the livers? So you are absolutely right in saying that it might not be the answer to everything, and that's exactly why it's so important that we study as soon as possible what the actual mechanism of the disease is, so that we know what we are dealing with. Because just replacing the nucleoside balance might not be enough for this disease in any case, regardless of whether you are able to correct the liver damage or not. So working on, just targeting to the liver might not be good enough, but there are enough evidence that nucleoside replacement therapy targeted to other organs may also be useful. DK2 is a very well-studied model of mitochondrial DNA depletion syndrome, where nucleoside therapy does seem to be helping, but again, it may prolong life, and it may make things a little bit better, but it doesn't necessarily cure it. So we do not have a cure for this disease at the moment, and I'm under no illusions that nucleoside replacement therapy is going to be the answer to everything. So we definitely need to learn to figure out what it is that actually is causing the disease and what underlies the actual defect in this protein.
A lot of work still to be done. Thank you so much, Surita, and thank you, Machaba. Great question. So let's move on to our final speaker. I have the pleasure of introducing Dr. Mariam Mahomed, who is a chemical pathology registrar at the Division of Chemical Pathology at UCT. She obtained her medical degree from UCT in 2013, and in the 10 years since then, she's got a lot of valuable clinical experience, but motivated by academia and research, she has transitioned into the field of pathology, and she's particularly interested in inherited metabolic diseases, and also really wanting to contribute and very passionate about getting that newborn screening program available to all in South Africa. So thank you very much for joining us, and over to you, Dr. Mahomed.
Morning, everyone. Sorry, I was muted. I'm very, very happy to be here and to share my study with you. This is the first time I'll be presenting these results. Hopefully we don't go over time. I'm just going to stop the video to minimize bandwidth use, but we'll get started now. So we embarked on a reference interval study for the measurement of thyroid hormones on cord blood for congenital hypothyroidism screening, particularly in the southwestern substructure of the Western Cape. So I'm just going to talk about congenital hypothyroidism, what is the definition of congenital hypothyroidism and the impact, why is it important for us to do research into this condition. We'll touch briefly on the current status of newborn screening in congenital hypothyroidism globally and within South Africa. And then we'll talk about the importance of reference intervals and then how we went about doing our study and the results that we got. So the simplest definition of congenital hypothyroidism is a thyroid hormone deficiency that is present at birth. Congenital hypothyroidism, in initial studies many years ago, it was initially thought to be about, the prevalence was initially thought to be about 1 in 7,000. But in countries with robust screening methods, the prevalence has been noted to actually be 1 in 3,000. And congenital hypothyroidism is an important disease to detect because it is the most common cause of preventable intellectual disability and growth delay. In many countries, with the introduction of robust and reliable immunoassays, newborn screening for congenital hypothyroidism was established as early as the 1980s in many sort of first world developed countries. It's important to remember that congenital hypothyroidism may be transient or permanent, and the transient form is mostly due to maternal factors such as iodine deficiency, maternal thyroid autoantibodies, or maternal use of antithyroid medication. One of the big barriers to establishing screening for congenital hypothyroidism is the timing of the test. And to understand this problem and to be able to assess thyroid disorders that occur in the newborn, it's very important to be familiar with the physiology of thyroid hormone production and control in the neonatal period. It's good to be also familiar a little bit with the embryology of the thyroid gland and also what the thyroid function is in utero, but we won't go into that in too much detail. What is important is that there's a significant transition from intrauterine to extrauterine life. And this results in several changes that stimulates the neonatal thyroid hormone production. The neonatal pituitary gland is stimulated to produce TSH in response to the dramatic temperature change from the warm intrauterine space to the cooler extrauterine environment, which leads to a TSH surge. The TSH in neonates rises to a peak about 30 minutes after delivery, and the T4 concentrations peak at about 48 hours. The TSH will normalize in 3 to 5 days, whereas the thyroxine takes several weeks to normalize. Ideally, newborn screening should occur between the 2nd and 4th day after birth, when blood is taken from the newborn. In most countries, it's done on the 3rd day. The reason for this is that testing before this time may lead to falsely raised TSH measurements. It's important to note that neonates with postpartum complications such as sepsis or lung disease may have a low T4 and T3, which is in keeping with sick thyroid or non-thyroidal illness. Congenital hypothyroidism may arise from a direct abnormality of the thyroid gland, which is known as thyroid dysgenesis, or an inability to manufacture, secrete, or respond to thyroid hormone, and this is known as thyroid dyshormonogenesis. The other difficulty with congenital hypothyroidism is that the picture is very subtle and non-specific. Often there are no clinical features, and this is because of the presence of maternal thyroid hormone in the newborn. But if there are clinical features, they are very non-specific features such as prolonged neonatal jaundice, macroglossia, delayed closure of the fontanelles, constipation, hypotonia, and then most common reason for these patients presenting to eventually finding their way to the endocrine clinic is developmental delay. So Early detection and prompt treatment of congenital hypothyroidism is critical to prevent this irreversible intellectual disability and growth retardation. And this is when newborn screening comes in, because newborn screening plays a vital role in identifying affected infants as soon as possible, allowing for timely initiation of thyroid hormone replacement therapy. Currently, the recommendation is to start thyroid hormone replacement therapy within 2 weeks of birth. And there have been multiple studies and audits that showed that the implementation of congenital hypothyroid screening in other countries has significantly improved outcomes for these infants. But unfortunately, in South Africa, there's no state-sponsored newborn screening program for congenital hypothyroidism. What does exist is limited to the private sector, which serves less than 20% of the population. And there are a few limited newborn screening programs for congenital hypothyroidism available in the public sector. And one of these programs is the Peninsula Maternal and Neonatal Services Congenital Hypothyroidism Program, which is currently active in the sort of southwestern substructure of the Western Cape. But the biggest barriers to newborn screening in South Africa include resource constraints, sort of access to healthcare, which is a current problem and a historical problem, and again, the timing of sampling. The timing of sampling is difficult in resource-constrained countries because in sort of developing nations, early discharge post-delivery is advocated for. In South Africa, if a woman has a normal delivery at a maternity and obstetric unit, she's discharged within 6 hours of delivery if all is well. And that makes it quite difficult for us to implement screening using newborn heel prick test, either serum samples or dyed blood spot testing. So most commonly screening is performed in the neonatal period using dried blood spot testing. And then in countries where early discharge post-delivery is practiced, cord blood TSH is a better choice, with some studies showing superior sensitivity using cord blood than very early heel prick testing. And what evidence does exist does support the use of cord blood to screen for congenital hypothyroidism within the South African infrastructure. So this congenital hypothyroidism screening program that is part of the Peninsula Maternal and Neonatal Services was initiated in 1982. A 2018 audit of the catchment area of the PMNS indicated a coverage of 92.8% of all births in the area, which led to an estimated incidence of congenital hypothyroidism of 1 in 3,000 in the Western Cape, and that's in keeping with current worldwide figures. But the one difficulty that has been identified is that there's a very poor recall rate noted with this program. So this is either because patients are not aware or educated that they need to follow up this result, or doctors and nurses are not aware that they need to follow up this result. We also have a very migratory population where patients will come to the Western Cape to give birth and then go back to the Eastern Cape, and then calling patients back when we find an abnormal result becomes very difficult. The PMNS congenital hypothyroidism screening is currently being done by the Nuclear Medicine Department at Red Cross War Memorial Hospital, but unfortunately production of the total T4 assay has been stopped, and this is part of the worldwide move away from radioimmune assays, and the screening will soon be taken over by the NHLS. With this in mind, understanding that there are differences in the assays and the methods that are used to measure thyroid hormone, we decided to embark on a reference interval study. And this is important because in order to make rational management decisions using results from cord blood, we need appropriate reference intervals. And reference intervals may be affected by a wide array of things: lifestyle, ethnicity, gender, nutrition, and other environmental factors. And therefore, it's strongly recommended to establish reference intervals for the population to which it's being applied. So the aim of our study was to establish useful and reliable reference intervals within the South African population to be used as tools for clinical decision-making in the existing congenital hypothyroidism screening program in Cape Town. So in this study, there were various steps that we took in terms of selection of our participants, actually doing the reference interval study and the method comparison. And I'm just quickly going to discuss those and the results. We did get ethics from the Human Research Ethics Committee at UCT, and also the Department of Pathology Research Committee. And the study focused on residual samples that were collected from the Department of Medicine's Nuclear Medicine's Congenital Hypothyroidism program. And we used the residual samples and we ran them on our platform. It was a prospective study. We initially collected 1,007 residual samples from the PMNS Congenital Hypothyroidism Screening Initiative. And we've tried, because with reference interval studies, we need to focus on a normal population. We excluded samples that came from secondary or tertiary levels where it is more likely that the patients there would have some sort of complicated pregnancy. So we use samples solely from infants born at the maternity and obstetric units and district level hospital services. So we had 1,007 residual samples collected over 2 weeks. About 700 samples from secondary or tertiary levels were excluded in an attempt to exclude patients with complicated pregnancies. We also excluded samples with insufficient data, with insufficient sample to be run with an abnormal screening TSH or with very low birth weights. And we ended up with a cohort of 304 samples. And from that 304 samples, we randomly selected 121 samples. And then we also kept aside 14 additional samples. We didn't remove them due to low birth weight or abnormal TSH. And this was just for a method comparison study comparing our immunoassay method with the current method being used, the current RIA method being used by the Department of Nuclear Medicine. Just for the reference interval study, the birth weights of the sample group range from 2,500 grams to 4,120 with an average weight of 3,200. So we know that our babies were all within a normal birth weight. And of the 121 samples used, 37 samples came from babies born at Mitchell's Plain District Level Hospital, and the remainder of samples came from babies born at various MOUs, including Guguletu, Dunoon, Vanguard, Retreat. And this just goes to show that we got a good diverse population within that 121 samples. We did the free T4 measurements on the Roche-Cobas analyzer, and the data was assessed using the Shapiro-Wilk test. It was found to have a normal distribution. And given that we have this normal sort of Gaussian distribution with our T4, we will probably, we did an assessment in terms of the parametric, non-parametric, and robust values. But what we did find was our lower limit using the parametric method was 13.2, and the upper limit was 19.7. I didn't mention it earlier, but the current sort of medical decision limit being used for T4 is 14, and that's based on figures that were found in the literature. And we see that our value that we found from our study is slightly lower than that. The other thing to remember with the free T4 is that the upper limit is not as important as the lower limit, as we are screening for hypothyroidism. So rather than using a reference interval, we will likely only use the value of 13.2 as a medical cutoff for patients that need to be recalled. The evaluation of TSH values from the Roche-Cobas instrument indicated a non-normal distribution, and a non-parametric reference interval method was employed due to the skewed data distribution. And we can see that here it's got this right skewing. And using the non-parametric method, we identified a lower limit of 1.81 and an upper limit of 15.4. The current values that are sort of regarded as a normal reference interval is 1 to 20. So it's similar to our values. And the difference we postulate is probably just due to the difference in the immunoassay method versus the RIA method, the sort of electrochemiluminescent method. The other thing that's important to remember is that T4 and TSH are not standardized tests. So it does become an ongoing issue that are finding different reference intervals on different platforms. And then we did a method comparison study where we looked at the TSH values as measured on the previous RIA method, and we compared them to the Roche-Cobas method using Lin's linear regression. And we found that within the reference interval, there was a commendable level of agreement, but there was some bias introduced at sort of extremes of values. Sorry, I just see that there's messages coming. Okay, no. Sorry, I just saw the chat had a few messages. And And then just in terms of the limitations and the clinical impact of our study. So like I said, the current reference interval used for core TSH on the RIA method is 1 to 20. If a value measures less than 1 or more than 50, the patients are immediately recalled, or the plan is to immediately recall patients for repeat testing. But if it's between 20 and 50, this is considered a gray zone, where the patients are then referred to NHLS for secondary screening where T4 is measured. And the current T4 cutoff for callback is less than 14. And that is from the literature, where a similar assay was done on also an electrochemiluminescent assay method. I think it was also done on a Roche cobus, but it was in a different population. Just in terms of our findings in the study, our reference interval that we suggest from the study is 1.8 to 15.4, and the medical decision limit that we would suggest based on our findings would be less than 13. But before we can implement this, we need to table and discuss these findings in a meeting that involves the pediatric endocrinology team and the team that's currently running the congenital hypothyroidism screening project before we implement any of these findings. And then once we have implemented these findings, further audits and studies are needed to assess the sensitivity and specificity of these values, and also make an assessment of whether these values need to be tightened or loosened depending on how many false negatives and false positives we do see coming through the system. Just in terms of the limitations of our study, the one thing is that we were using residual samples. So the quality of residual samples can vary, the sample storage conditions, the handling of the sample, the duration of storage. None of our samples were more than 3 days old at the time of running them, but we also have very little not understanding, but there's very little literature on the stability of cord blood and if cord blood has different storage conditions, etc. And then another thing that we noted was because we only used samples from district and primary level patients, it does not adequately represent the full spectrum of pregnancies, but we were focusing specifically on normal pregnancies. And this does sort of lead to the idea of doing further studies where partitioning can be done according to weight or according to maternal illness. There are, in terms of the limitations, the assay methodology, we used electrochemiluminescent immunoassay, and we know that any immunoassay has the potential for interference. In terms of the testing that we did, the assay has a very low, sort of very high thresholds for interference by lipemia, hemolysis, or icterus, etc. But we do keep in mind that these immunoassays are at risk of interference. And then the other problem that we had was that the residual samples that we received have very little clinical data. They come with a very small form. We have a birth weight, we have a birth date, and beyond that, there's not really a lot of information on the baby or on the mom. And one of the problems that we do also have is that often when the babies are born, if it's very late and there's no clocks, that the mom stickers get put on the forms, which makes it very difficult in terms of continuity of care to monitor if that child has come back, if they come back with their own folder number, how do we trace it? And these are all things that are ongoing discussions in terms of the greater sort of congenital hypothyroidism screening program. In terms of the sort of benefits or advantages of our study, we were able to achieve an appropriate sample size to establish this reference interval, and this is based on the CLSI reference interval documents. And also using residual samples made the study more feasible, both in terms of cost and time, and also in terms of getting ethics. If we had to draw blood ourselves or draw blood from neonates, that would be a very difficult study to convince our ethics department about. The use of the residual samples are also more ethically sound than collecting new samples, as it minimizes the burden on patients. And then one of the big advantages of this program, and also of running this program through the NHLS, is the feasibility for continuous monitoring. because we have this ongoing, we have samples coming through on an ongoing basis, and if we can keep track on a database of this condition, it allows us to have a continuous monitoring system, so we can adjust our reference intervals as needed, and we can adjust our other parts of the program as needed, depending on the response to it. We did get good population-specific data. So it reflects the population that is typically encountered in the routine healthcare settings. And we also found that on the whole, our results of the study are in agreement with similar studies done on cord blood measured on automated analyzers. So just in conclusion, congenital hypothyroidism is a significant but preventable cause of intellectual disability and growth delay. And early detection of these babies, as well as early intervention, can prevent the devastating consequences associated with this disease. This study provides reference intervals and clinical decision limits for use within the PMNS Congenital Hypothyroidism Screening Program. And running these samples through the NHLS, the National Health Laboratory Service, allows surveillance of the prevalence of congenital hypothyroidism and consequent follow-up of patients. The study also allows for future investigations, such as audits on the reference intervals or medical decision limits, and forms an integral part of the journey towards comprehensive newborn screening in South Africa. Thank you.
Wow, great. Thank you so much, Mariam. I feel like we've really done an extensive marathon today of a number of conditions. And what's interesting about congenital hypothyroidism, it really is the poster child in many regards for newborn screening. But what you've demonstrated with this research, with the reference intervals and threshold levels, it demonstrates there are so many different variables that have to be considered when setting up an NBS program. Whether that's, that we've got the complications of the 6-hour discharge in state hospitals when there's a healthy mum and supposedly healthy baby. And we've got to counter that with all the different methodologies. And for example, the move towards not using cord blood and doing dried blood spots instead from heel pricks. My question to you is, do you have a suggestion in terms of going forward? Because obviously cord blood can still be used for dried blood spots going forward. But obviously it's not going to work if we want to use congenital hypothyroidism as kind of a placeholder and our primary focus for NBS if we want to expand it into other conditions, for example, cystic fibrosis. So we've got to find that sweet spot somewhere with all these variables. Where do you think that sweet spot is?
I think it's quite difficult in a South African setting to get this done, and it's various issues. There's a very big infrastructure issue. There's also a labor issue. One of the biggest barriers that we have is that the nursing staff in some units are not interested in learning how to do dried blood spots. They feel like it's adding to their work. They don't really want to do it. And then there's obviously the follow-up rates. There've been multiple studies that show that postnatal, there's a loss of follow-up in terms of postnatal visits. And the closest or the earliest postnatal visit that is widely attended is the 6-week visit, which is obviously too late for intervention. So I think in our setting, just in terms of congenital hypothyroidism, if we can successfully roll that out into other parts of the country, I think that would be a good step. And also, I don't know how familiar everyone here is with the South African healthcare system, but there is a Road to Health card. And I think that we should actually make the congenital hypothyroidism screening part of that Road to Health card so that it's a tick box that needs to be cleared. And then hopefully that is the foot in the door for newborn screening in South Africa, where people become more aware of it. And then we can start looking at conditions. I mean, ideally, we'd be able to find other markers in cord blood, but so far studies don't really support that. But then we can start looking at other common conditions. The other strength that South Africa does have is that there's quite a reasonable infrastructure around community health workers, and that is often related to palliative care patients and HIV our HIV positive population. But if we could make use of those community healthcare workers, if they could visit families within a period where we could still do a dried blood spot test, perhaps for other conditions. But this is something that needs to be discussed at much higher levels, in terms of, because the biggest problem that we have is infrastructure. But I do think that it's important to get something going, even if it's not everything, just so that the discussion and the interest in newborn screening, we can play on that momentum and keep it going.
Yeah, very nicely put, Mariam. I agree completely with what you've said. We've got to build on that existing infrastructure for other conditions that are already have got that network of community health workers in the community. And if they're taking blood anyway for HIV programs, then why not just take blood at the same time? I really like the idea of adding it onto the Road to Health card. I think that's a great suggestion. And yeah, I think it's not going to change overnight. We're going to have to keep pushing from all our different perspectives and at our different angles as different stakeholders. And I really think that if we keep going and keep publishing the evidence and putting pressure through advocacy work, that we can hopefully make this a reality for all South Africans. And I agree. I think getting congenital hypothyroidism out is really going to pave the way for other conditions. So we had no more questions and no more comments on the chat, but there have been some really nice feedback, like from Nabila, who's saying, thank you so much, enjoyed these presentations. Riona's said great presentations, and Jody. So thank you so much, everybody that's contributed and participated online. We had a really good show today with over 50 participants. So thank you all for joining us. Thank you, Sarah, Surita, and Mariam, for a great presentation. The discussion doesn't have to stop here. If you have more questions, more comments, please feel free to drop them in an email to genetics@rarediseases.co.za, and we will make sure that the question gets to the appropriate speaker. Please join us again in November for our final Rare Research webinar of the year. And yeah, just keep up the hard work as we go into that last quarter of 2023. Thank you so much, everyone. Sorry for running over a few minutes, and enjoy the rest of your day.